Hello, everyone, and welcome. I'm Linker Mills, and I'll be your host for today's webinar. Thank you for joining us for No More Than the Investigators, Risk and Data Mining. We're excited to have you here with us today. Healthcare enforcement is evolving rapidly, and regulators, payers, whistleblowers, and investigative agencies have access to more data than ever before. The question isn't whether your organization is generating data, it's whether you're using it as effectively as those scrutinizing it. I'm pleased to introduce today's presenters. Charlotte Kohler, president of Kohler Healthcare Consulting, brings more than 30 years of experience in healthcare finance, compliance, reimbursement, investigations, litigation support, valuations, and regulatory matters. Her work spans complex healthcare disputes, fraud and abuse investigations, compliance reviews, expert witness engagements, and operational improvement initiatives. She is widely recognized for helping organizations navigate some of healthcare's most challenging financial and regulatory issues. Joining her is Kalita Burton, Vice President of Kohler Healthcare Consulting, a healthcare, finance, and reimbursement executive with more than 25 years of experience in revenue integrity, reimbursement strategy, regulatory compliance, managed care, and financial performance improvement. She partners with hospitals, health systems, physician practices, and post-acute providers to strengthen financial outcomes, reduce compliance risk, and improve operational performance. Together, they'll reveal how data can help organizations stay one step ahead by identifying vulnerabilities before investigators find them. Next slide, please. During today's sessions, you'll learn how data mining is reshaping healthcare investigations and enforcement, how organizations are identified and assessed using publicly available information and data analytics, and then finally, practical steps healthcare leaders can take to understand, monitor, and mitigate their own risk exposure. With that, I'll turn it over to Kalita.
All right. Thank you so much, Linker. And again, welcome everyone to today's webinar. So where we want to begin, we're going to start with how the investigation actually begins. Next slide, please. For a long time, the answer was simple. Investigation started because someone filed a complaint and your hospital or the physician or someone came up within a routine audit, which still happens today, but how investigations started in the past is no longer the main path of how investigations start today. Today, most of the investigations begin with your data. It's your claims data, your billing patterns, and the information that is already publicly available. Investigators, they look at what stands out. The provider whose numbers do not look like everyone else's. They're looking for these outliers either in volume or in reimbursement and total charges. They're looking for what stands out. They're also using the same information that you already own in your systems, right? It is your data that they're beginning to use against you. So the question is today, if someone ran your data, what would they see? Next slide, please. So at Kohler, this is how this scenario plays out for us. We often get a call. Sometimes it's from the provider, sometimes it's from the attorney. Either way, the client has received a civil investigative demand or a CID. And no one within the organization, of course, saw that it was coming. And so our first response is always the same. Yes, we can help you. Sure, we can help you. But our very next question is the one that matters. Did anyone see it coming? And almost every time we ask that question, the question is always no. And by the time, you think about when that CID, that demand letter comes in, it's already too late because someone from the outside has already been looking at your data for many months now, and they've already built a case against you. And now your organization is reacting to a story that has been put in motion months ago. So with that in mind, the good news about that is that the signals are typically always there. Your organization, you own your billing data, you have your claim data, but no one is looking at all of the data as a whole. We're always looking at like little parts of something. So the next question I want you all to keep in mind today is if a demand letter arrived at your organization tomorrow, would you already know why? And just one another thing that Linker mentioned earlier, and I just want to emphasize that anytime if there are questions, don't forget to put them in a Q&A chat. If we can go to the next slide, please.
That brings us to our first poll question, folks. So, how do you believe most healthcare investigations begin today? By A, an employee complaint, B, a patient complaint, C, routine audit, or D, data analytics? You should see a poll pop up on your screen, and please answer that, and we'll look at the results here in just a few minutes.
All right, what we're seeing right now, data analytics is a major driver. We also see there's a response with patient complaint. Let's see how far are we in. We have about 57% of the attendees have responded, but 91% of those show that it's based on data. So that's where we are today. Investigations begin with your data. So I'll share results and you all can see them on your end, and then I'll stop sharing and we can go to the next slide. So thank you all for participating in this poll. It's always good to know what your thoughts are in this. All right, so who are the players in enforcement? Your healthcare investigations, again, no longer beginning with a complaint from the patient or even internally, right? No longer relying on random audits. The data miners are hired by the DOJ, CMS, UPICS. You also have analytics firms that are out there, even some consulting practices, your payers, your whistleblowers, which could be people from the outside with a computer or people internally within your organization, recovery contractors, attorneys, the OIG, you name it. All of these organizations has someone that is mining your data. The important takeaway here is that they are not relying on secret information. Again, your claims data, your billing data, your reimbursements, all of that stuff is publicly available. And all they're doing is looking to find patterns so that they can report you to CMS or to the OIG to begin an investigation. And if they can use that data to identify potential risk within your organization, you should also take the same approach to identify and address any issues before they become an investigation. So we can move to the next slide. So we wanted to give you a little bit of perspective, just in case you missed it. The 2026 National Healthcare Fraud Takedown shows that the size and reach of today's enforcement efforts. So while the slide is focusing just on what took place on a Medicaid level, let's look at it globally. There were 455 defendants that were charged, including 90 medical professionals in this Medicare takedown. More than 6.5 billion was alleged false claims. And of that, 295 were Medicaid defendants, and they were tied to about $518 million in alleged false claims. It involved 50 state Medicaid fraud control units. There were 56 federal districts involved, and it spanned 45 states and territories. And all of that, with those Medicaid providers, the government seized about $182 million in assets, homes, jewelry, you name it, they took it. CMS also suspended over 1,000 individuals in organizations from billing the federal Medicare program, and they also revoked the billing privileges for another 1,400 individuals. So based on the analytics and the cross-referencing of the data and various sources, the prominent component was the takedown. They were pulling data from different places. The government is increasingly using the data analytics to find these unusual billing patterns so that they can identify potential fraud faster. The providers, for you, this means knowing what your data looks like, watching for those outliers, and addressing any unusual billing before it becomes an enforcement issue. At the end of the presentation, you'll see all of the resources, and you can take a look at that article on your own for additional information. Next slide, please. So what about the internal or the non-payer sources of risk? There was an article, Surgeon Settles FCA Case Set in Motion, by data miner whistleblowers. This was reported in the Medicare Compliance and the May 18, 2026 article. There was a California physician who agreed to pay $6.73 million to settle a false claims allegation. This individual was a high-paid nephrologist. While they did agree to the settlement of $6.73 million, they did not admit to liability. But the whistleblower in this particular case, it was an outside analytics firm, no ties to the provider, but an outside company. They used publicly available data, and they were able to pinpoint this particular nephrologist as being one of the highest paid nephrologists per beneficiary. So of course it was an outlier, right? In that data, there were about $5.9 million in vascular procedures billed, which is 30 times the average of any other provider. In that particular practice, they collected about $17.5 million in payments, and they only, they settled again for the 6.73 as a payback. So we are at the end of this first section. I know it was a lot about data and statistics, but we will check in the chat to see if there are any questions that you may have about what was presented so far or any aha moments about this. Just knowing that the DOJ says that more than 45% of the complaints are coming from whistleblowers since 2024. They're coming from people that are just basic data miners, anyone with a computer and the wherewithal to look at data and to do analysis. Do we have any questions in the chat?
No, Cleta, there aren't any questions.
All right, so thank you. At this time, I will turn it over to Charlotte. Next slide, please.
So actually, you have probably all the data you need. We have a tendency, and we're talking about this from a compliance perspective, that over the years, we've said, all right, on a normal compliance basis, we're going to look at maybe 10 records per doctor, or some method that way. What we're really looking at here is that there are so many areas that you can bring together and that you can do comparisons on. We see we have a question here, which is good. How do you get other providers? Let me address that in a moment. So, for example, if you have a lot of primary care practices or orthopedic practices or whatever, we often tend to look at the detail, a couple of records, but no, we don't look at the patterns. And what we're trying to do here is to say, what patterns can you see internally? And then as the question was asked, where are there other outside data points that you can use? There are an incredible number of those data points at CMS. There's also a lot of statistics and data that is being provided through different organizations, whether it's a primary care or a specialty practice, or it is in fact looking at different hospital data. So we want to look at taking compliance from just let's meet and check off the boxes to let's do something really more invasive. Let's see what we're doing and why we're doing it. Let's go to the next slide, which is a poll question.
Yeah, thank you, Charlotte. That does bring up our second poll question. So, has your organization ever performed an outlier analysis on itself? So, answer A for yes, B for no, or C for not sure. And that poll box should pop up anytime now.
Apologies. That was all on me. Sorry.
Did not coming up. Yeah.
There we go.
Thank you.
All right. So it looks about 67% says they're not sure. 22% says yes, and 11% says no, we're still moving. We have about 50% participation. 70% is still the outlier saying that they are not sure.
Now, this isn't surprising because I think that all of us with the limited resources that we have, we end up with having, we can go to the next slide as I talk. We look at our reporting, which is often sort of financial reporting, reporting by department, whatever. But when we talk about moving beyond what was the results, for example, last month, we need to move to a point of saying, what is our trends? How can we use some of this software that we have to take a look at trending and say, am I going the right way? Is there problems I need to handle? So often we think about it, it's compliant, very one-on-one. I look at a record, I look at how it's billed, I get paid for it, I'm happy. But that whole method is on a one-by-one basis. It's almost like looking at the trees and not the forest. We really need to move to what are the outsiders looking at? They're looking at our trends. So we need to really focus much more on the trending and then look at our risk. As we go through, there are the Medicare utilization files, the PUF files, as we call them. A lot of information there. The cost reports, yes, cost reports still count. They still look at things that we should say, does it make sense? We look at the open payments. We have a lot of information on payments. Do we have a problem that looks like a payment problem, but it really is probably a utilization problem? PEPR reports, been around for a long time, have come back. Again, let's see what an outsider, the government, looks at you as far as what you are coding for the various types of diseases that they're keeping track of in the PEPR reports. And then certainly we have all of the quality data. So quality data can also be converted into compliance data. What are we doing and how is it working? Go to the next slide. So the poll didn't surprise me. I don't think it surprised any of us because we have the data, but moving from having the data and utilizing the data to a point of saying, what is my risk, is that next step that can focus in your limited resources to actually attacking the risks. I'll talk for a moment, take a system, Epic is one of them, for example. We have data that's stored in the query, in the database that's used there. Can we get that data? Can we analyze it differently? Yes, with revenue integrity, they're looking at, are the right charges going out? Do we have integrity in the billing that we're doing? But I think we need to really start looking at how can we do it not on a one-off, but how can we replace some of just our financial statistical data with a risk analysis that allows us to keep very current and involved. Next slide. So here's an example, just an example of I take my data rather than sending it out with all the Excel spreadsheets and stuff. I'm now actually looking at it from a standpoint of internally, do we look okay? So as you look at this spreadsheet, what you're seeing here is that we have different doctors, all in the same specialty, for example. What do they look like? We can go further. What's their use of a modifier 25? Is that like raising your hand and saying, hey, come look at us? Or the use of incident 2. There's many, many different things that we can do with our data, because an outlier doesn't mean it's wrong. An outlier means, can we support what that outlier may tell an outside investigator? And if we can, good. If not, we go into our records, we see what improvements we need to make and to mitigate our risk. Next slide. We know that even when we get data, especially, for example, when we get our explanation of benefits, we get the payment vouchers, they have CARCs and RARCs on them, for example, they may not be the correct ones. The reporting from our insurance companies is sometimes very questionable. But when you pull that kind of data in and you start seeing how it looks unusual, why are they denying, changing, reducing payments? The next question is, one, is that right? Yes or no? Are they meeting their contracts? But what risk do we have relative to these kinds of reports back? So looking at that broad spectrum, focusing in on individual providers, individual specialties or services is extremely helpful. You can get your data for other organizations, and it's cleansed, but we can get a lot of that through CMS. So we go to the next slide. Using the analytics is to identify risk. Oftentimes we use it for financial. It is financial, but we want to make sure that we can do more with it. And so it means that we need to call upon our IT people or have someone who's analytically involved internally that can move from Excel to a database to be able to slice and dice this and be able to pinpoint, what do I want to look at? Why do I look different? Is it okay? And that's where we get into, I think, the exciting part. And I'll just mention offhand, sometimes when we get the work on the notices from the government, the CIDs, one of the things we do, they're looking at, they've already done that data analytics. They've got it in their back pocket. They're asking for particular things. We're coming in and saying, let's look at the data. What are they really seeing? So you want to get into that mode of looking at it as if you're the investigator yourself. Next slide. With AI, we know it not only is challenging, but it's also very, very important that we recognize the usefulness. AI is not going to get rid of people. What it's going to do is it's going to help us focus on exactly which ones we want to look at. Where do we want to spend our time and our dollars? CMS is definitely on this track. We know they are. Many of the payers are on this track. And quite frankly, when we look at the payer side, we recognize that they are looking at data coming in and as moving to, as part of the adjudication process, evaluating that and whether they should pay it or not. So as we go to the next slide on this, we go to what Medicare is doing. Medicare's been doing this. They've been doing it through their different investigation arms, as Kalita has said. But they have, in fact, announced that they're using this CRUSH initiative, comprehensive regulations, to uncover suspicious healthcare. That's their setting. Their setting is, we think that what we're getting in is fraudulent, we want to look at it. We want to move from a pay and chase model, which is what we have now, which is why the Medicare claims get paid so quickly, to a detect and prevent, meaning we want to do what the other commercial payers are doing. We want to know whether we want to pay it to start out with. So they're doing it in steps. We don't have all the information on it, but we can see that they are, in fact, slowing down provider enrollment. They are looking at their analytics. They're looking at what's going on, and they have identified, not only just identified the high-risk areas, for example, wound care, but they are looking at the individual billing that's going through. They are pushing for that front-end work and not a let's get your money afterwards. Next slide. So here is what you should know about. This is the CRUSH program. I don't think, as at least I think when inside Kohler, when we've talked about this, is like, well, no, they just simply took what we knew they were doing and they listed it on the kinds of things that we should anticipate and what the provider should do. And part of our goal in this session is to say, can you look ahead and not get buried with the current problems? Because that is one of the challenges that we have, is the monitoring of the services. Next slide. Well, as I said, definitely payers are using AI. Definitely we are seeing that they are being very, I'll use the word judicious on what they want to pay for. They are looking at their contracts, they're looking at what their policies are, they're applying that within the AI, within the adjudication programs. They're going to be moving away, and have already moved away from, spot checks. They're going to say, these are the ones we want to look at, and these are why we want to look at those. And they want not only the medical records, but they want all of the authorizations and approvals ahead of time. Next slide. So I've touched upon denials. Denials are ugly. Denials mean, let's just face it, you provided care. You spent the money to provide that care, and now you're not getting paid. And when we get reports that come out, and we've listed quite a few in the back here, where 1 in 10 claims are not being paid, or 19% of the in-network, in other words, you signed a contract, but they're still denying 19%. And of course, as an out-of-net, you would expect a higher rate because there's that negotiation that goes along with it. Different organizations have said it's the front end of the revenue cycle that causes most of the denials. And we've had some work from CMS and United to try to reduce the amount of denial rates. But even with that, what we find is, and we know this, is handling the denials, the amount of time and effort and cost that goes along with this. So it's not surprising that AHIMA says that 60% of the denied claims are not resubmitted, and Waystar says as much as 65%. That's a lot of money. That's a lot of effort. That's a lot of, can we get it out the first time? We give this first pass rate, but we want to keep it after it goes out. So we have the denial on the front end, and then we have the keeping it on the back end. And of course, very, very frightening and painful that less than 1% of denied claims are appealed, so that next step up. But when they are appealed, 56% of them get reversed. So it's worth our time and money, but that's a lot of time and money. So let's go to the next slide, please. So where does AI help us in this? Well, I think we go back a couple of years, and the first thing, the worry was, oh my goodness, we're going to have AI take over our coders. But that's not really true. AI should be helping us identify where our very experienced coders can go in and make changes. What's systemic? What can we fix? That's where we want to use AI. We want to find out not only what's missing, what's wrong, what can we fix? Because if we fix it, we don't have to go back and fix it again. On the other hand, there may be situations where you end up in a situation where the payer simply is ignoring what they should be paying. And Kalita and we within Kohler end up doing that a lot with payers who have changed the rules, even though you didn't think they changed the contract. On the next slide, I just want to talk about just some of the other risks. I mean, there are risks that are not per se coding. Some of them can be risk of how many services that a provider perform in a day. Does that make sense? I mean, can they actually see 60 patients a day? If you had wound care or PT or psychiatric services that have time associated with them, you can do some simple math and figure out whether I might have a problem. Or it might be a problem of they're using incident 2 and we're not identifying that properly. Or they're doing other kind of services that increase the volume that makes it look like it's a problem. If it looks like a problem, you need to be prepared for it. Somebody else is looking at that, and as Kalita said, there's a lot of IT people out there that have access and can get access to data, and they may be that's maybe their mode of making income, is to figure out what they can whistleblow on. So there's just a lot of risk that when we look at that data and we can drill down on it, which is why I'm moving, and we've moved so much to databases as opposed to Excel, to see what kind of correlations. Let our fingers do the walking on that and let us figure out whether it makes sense or not. So I think Kalita,
Yeah.
Kalita.
Yep. Thanks, Charlotte. Before we move on, though, I know that there was a question in the chat. I'm not sure if we addressed it. It was, let's see, it is one thing to obtain our own data, but how does one obtain data from other providers to compare to?
Yeah.
So that information, the public use files that Charlotte mentioned, are available on CMS's website. What we can do at the end of the presentation when we send out the slides, we can also include some links for the public use files. There are some agreements that you all have to agree to with obtaining the data and using the data. But yeah, we can share some links with you. And then Dawn, I think there's another question out there.
The other it was basically the same. What are the sources of publicly available data that the data miners can access, and can everyone access them?
Charlotte, you want to answer?
Yeah. Well, yes. And I think there's also, if you're members of organizations, or if you're, for example, a hospital that has many other hospitals in your organization, you have the opportunity to be able to share data that would allow you to assess risk. And you have to work carefully through that. But again, look at where you may have other sources of data. And we'll get the links out to you for some of the others. But it is, we end up, just quickly, when there's questions about pricing or volumes or things like that, we're looking for collaborative data. It's around. It's not as good as we'd like, but I'm keeping in mind that the payers are gathering that. They don't have any problem taking every orthopedic practice on the East Coast and matching it all up. So here's another question. Is there a standard AI program that hospitals can use for data mining? At this point, yes and no. There are vendors out there. And even Epic and Meditech and some of the others have been putting together some data mining kinds of things. What I am also going to suggest is that you have access to or provide training internally so that you can move away from the concept of Excel only. Because the data coming in, there are times, for example, we take the data from the 835 and 837s. and we match it up. Now, that's a little bit higher level than I would expect my patient financial services to do. I mean, but if it's a one-off, you can have somebody from your IT department, or you can contract to get somebody to put that together for you and then build on that and learn how to do it. I have this thought that I think on the hospital and the provider side, we're in our infancy. On the insurance company side and CMS side, they are definitely well on their way of taking this robust data and putting it into it. And I use a little lingo here. The 835 and the 837s is the electronic files that we send out the data on the 837s. They go through the clearinghouse if you're using a clearinghouse, and then the monies come back in on the 835s. They're actually electronic files. You can actually pull that data in. And there are times when we've done that where we look at the CARCs and RARCs and we go, this doesn't make any sense. Why are they denying it for this reason? Or why are they doing a line item denial and removing monies that we should get paid? You can't do that on a case-by-case basis. It is just too much data and too much information. But getting it accumulated and then seeing the trends allows you to focus on that trend and say, this is what I'm going to do about it. So this is a very, I think, exciting time where we need to look at our capabilities and also say, who are we going to have to help us internally to move through that? There's some other things. Go ahead. I'm sorry, Kalita, you were going to mention something?
Oh, I was just going to mention, I guess most of the AI programs that are out there, while we're not going to name drop specific vendors, but they are using like OpenAI Source, which is kind of the algorithm that's kind of out in the market today, and Epic and other EHR vendors do have a patch relationship with OpenAI to begin to build those algorithms. And then someone asked the question, what's the 835 or 837? The 837 is the electronic claim that providers send to payers for payment. And the 835 is the electronic remittance advice that comes back with the payment or denial information. That was all I was going to say. All right. Are there any other questions, or Charlotte, any other thoughts on AI?
No, I think we can go on.
All right. So next slide, please. All right, so we are now at the point where what can you all do to get ahead of the data mining and the investigations that are yet to come? What took place, or what was reported back in June of 2026, the Medicaid takeover? That again was the largest investigative investigation that CMS, DOJ, and et cetera have experienced. And so that is just the tip of the iceberg, right? We've covered a lot about the risk. And so again, how do you get ahead of it? The rest of this session, we're just going to look at the practicalities of it, not necessarily you all overhauling your compliance program, not going out to buy an expensive platform. So I know there was a question about like, what AI tool can you use? You don't necessarily need to invest in additional software, but understand the data that you have and understand the capabilities of your data analytics analyst, and begin to look at your data differently. So, you start with something that's easy to pull, right? You can pick one or two areas where you already know that there likely might be some exposure risk because you've already done maybe a random sample or a 10 record sample, or you've received a lot of denials in one particular area or for one particular provider. You can start then with just quantifying the worth, the total charges that are impacted, the total reimbursement dollars that are impacted, so that you can then begin to report all of this information to your executive team so that you get the full attention, right? You want to kind of use the data that you have and then bring an awareness to the organization, because is likely in the future, if not today, tomorrow, but people will begin sending investigation demands and CIDs and et cetera to your organization. You can also look at your audits that you're doing within your compliance program, any results that are there. If there is continued education that you are providing to a particular provider, that might also be a focal point for you to start because obviously there's something wrong with either the documentation or the coding. So when you're looking at everything as a whole, you want to look at you can start with the focus on the two areas, but look at the data at a higher level to get a bigger picture. So we'll walk through that a little bit. We can go to the next slide. So when we think about what payers do, the payer, they are doing a deep dive probe of your data. When they do that, you see it in three places. You see your denials, right? We talked about the denial rates. We also talked about the appeal rate. Your denials are going up. Then you also see it where your coverage is beginning to tighten. The pre-authorizations that you used to get for these routine services are now being scrutinized even more. They're asking for medical record documentation. They're asking you to prove medical necessity even before the services are provided. When payers are doing their peer-to-peers from your organization with the provider, the payer's provider, these peer-to-peer reviews are not always resulting in a pre-authorization being awarded to your organization. You also see it where the payers are starting to identify potential overbilling. They're looking at your billing patterns. Rather than looking at one individual claim, you'll see an organization, let's say ABC organization, coming in and saying, hey, send us, the medical records for 50 patients, or send us all the data you have. They're starting to do these data requests from you so that they can also look deeper into what you have. The payers identifying the overbilling and the billing patterns is the tricky part, right? Because when you are billing your claim for the billers that we have out there, and for those that are not, the providers provided a service, the coders coded the claim, and now it's time for patient accounting to submit the claims to the payer. When you are looking at your claims on an individual basis, each individual claim looks fine on its own. You don't see something wrong. The coding is correct. The NCCI edits have cleared, right? Because you have all of that built. The different edits and the payer requirements are built into your clearinghouse system. The documentation is there. The physician documented the services and the dates, and you have progress notes from the nurses and et cetera. All of the documentation looks fine. But when you take a step back and you look at it from a payer's perspective, there are hundreds of claims together. Now, the data that appeared fine on a claim-by-claim basis begin to look it's questionable. And that is what the payers are looking at. And what you see is the results of a CID coming in. So providers and business partners to providers, when you are there assisting, patient accounting or reimbursement, whatever department you're working in, you have to begin to look at the data the way the payers are looking at the data and probe from within. Next slide, please. And so what are the payers saying about the need for AI, right? We're not going to dwell on this very long, but we know AI is of the world today. We're using it in social media. Every little generative face you put out there has some type of AI on it, right? But what are the payers saying? Mostly they are now utilizing AI for member support and for customer service. We see that when we call on the phone and we're like prompt and pressing all these zeros and zeros and zeros and ones, and there's someone feeding back. It's not a person, it's AI. They're also using AI to identify care gaps and safety concerns. AI is used for predictive risk modeling. So again, they're looking at the data to see if there's any risk anywhere. Research and support, administrative simplification, and Lastly, they're looking at it for payment integrity and fraud detection. But realistically speaking, and not to put the payers in a bad light, because every organization today is looking for cost savings. Realistically, they're looking to AI for payment integrity and fraud detection. Because if they can identify where they're overpaying you, even if your organization did not intend to defraud the healthcare system, they're looking for cost savings. So if there's any way for them to pay the lowest amount possible while staying within your contract terms, Charlotte alluded to this a little bit. You have your contract and it says you get paid an inpatient, DRG according to Medicare. Your outpatient is a percent of charges or whatever it is. But then these contract terms are beginning to change because policy documents are now being introduced to change how you get paid. This is what they're looking at. They're comparing their policy documents against your billing patterns and then saying there must be something wrong, right? So it also would behoove you all to really understand what your contract says and make sure you're staying out on the payer websites to see what those policy documents are as well, because there might be some reimbursement language in there that will begin to conflict with what your contract says. We can go to the next slide. And then we're moving again from your claims data to a targeted investigation. And this is pretty much how your claims review becomes a targeted investigation. Claims have been adjudicated electronically for many years now, right? Using the electronic transaction standards reestablished through HIPAA. So the data is already organized and is already being read. The public use files are out there, your claims data. It may not identify, your particular organization, but your claims data is out there. But not only your claims data, also the payer data is out there as well. What they're saying is the patient's cost sharing amount. The whole health exchange data is out there. Copays, deductibles, et cetera, benefit levels. CMS is also collecting that information from commercial payers as well. So when we're beginning to look at the outliers, they might look at your hierarchical condition codes, your HCC codes, to determine whether or not the codes are really that are there are pushing the Medicare severity, which is impacting the payment that you're receiving. They're looking at whether or not, either a provider or a patient, they're looking to determine whether or not your evaluation and management codes are just, on this rolling coaster bell curve that's out there where, you have for established patients, for example, a level 5 is always being used for one particular provider, maybe at 20%, but the industry average is about 1%. That data is available. And regardless of your diagnosis code, they're not really looking at the diagnosis. The diagnosis means absolutely nothing to them. They're really looking at the frequency of the particular services that you are provided. Does one particular provider have, every time there's, I don't know, a sepsis case, is the treatment pattern always the same? Are these particular services always provided? That's what they're looking at. Notice one of the things that's not on the list, providers, they may ask sometimes, payers may ask sometimes for your medical record, but they're not really looking at your medical records. Your whistleblowers, the data analysts, the OIG, DOJ, they're not looking at your medical records at this stage. They're just literally looking at the data you have, comparing it to the peers within your geographic area, but also nationwide. That's what they're looking at. And again, if they can do that, you can do that as well. And again, we'll give you the links to begin, so you can see the type of data that's out there. But where you can start within your organization is just testing in these first 3 areas. Look at your HCCs, look at your E&M, look at the particular service types, look at the CPT codes, do a frequency by provider and see if there's something that's standing out there. We can go to the next slide.
Kalita, there is a question that came in.
Oh,
It's,
sure.
can you elaborate on how quality data can be used in compliance to evaluate claims?
I'll do that one.
Okay, Charlotte.
I'll do that real quick.
Mhm.
So when we get quality data and we look at what kind of services are being provided, you look at that and you look at your own organization and you say, am I matching that quality data with what we get from some national data banks on quality? It's not a direct correlation. So it's one of those things where you need to take a look at what you're doing, what's being reported out on quality, and does it look like there's a match on that? So it's not like I can say a percentage of this is shown in quality data to be where you should be. And it's a little harder to get there, okay? So the other thing I want to just sort of mention here, and Kalita, I know we got the next slide because we have all this data here that just sort of pulls it together.
Mhm.
And that's a nice graphic. We can go to the next slide. You have all this data. So let me just wrap it up here real quick, because I know we have our time limits. One of the things that we can go to the next slide, which is the key takeaways, that we need to be really aware of is that these payers have contracted with organizations to go back and look at your data and do a review and pull back money. We see that too often, and that pullback can be 6 months later, 2 years, 3 years later, where they go back and they say, oh, there's too much sepsis here, can't be right, we're just going to pull it all back. You send them the records, you see it says sepsis in here, the doctor has documented, and they say, oh, too bad, we think it's not really sepsis. There's a lot of conflict going on here, a lot of money being made off of your backs. And so I think what we want to do here is we want to make sure that we know what's going on. We want to know what they look at and what they think of us. And we can only do that by knowing ourselves what we look like. Use your analytics to utilize your resources on where's my risk and where should I spend my money. And then make these analytics part of your compliance program instead of just looking at it as the analytics for billing, coding, and collection. That's really where we wanted to end up here, was to really make sure that we are getting as much ahead of the game as possible, because those third-party payers have every incentive to deny payment and keep the money. That would be my summary. Kalita, you want a summary there too?
Yeah, I think that's, a great end to today's webinar before Linker goes in and does final closing. But yeah, I echo everything that Charlotte mentioned. But the best way to get ahead of this, as she mentioned, is really to understand the data that you have in your system and get away from the tradition of truly the 10 record review that we like to do. You have to really look at the data on a bigger scale. And one of the things is also assessing internally within your compliance department or within your IATIS department. Do you have data analysts there that can really start looking at this at a different level? It might be a resource that you have to invest in, get another FTE or two to begin to do that, and have someone that is solely dedicated to looking at data and trends and making sense of what it looks like, because that's what they've done on the outside, right? They have data analysts, and they're also, when they're using AI for all of this, the algorithms are there. They're not, once they find that set algorithm that works or that script that works, they are really just pulling new data in and pulling new data in and going from provider to provider to provider to provider. So once you figure out where you stand with your data, it's already built. And now all you need to do is keep refreshing the data to see if anything else is being identified with it. So that's kind of all I have. I'll turn it over to Linker for closing remarks.
Thank you so much, Kalita. Next slide, please. As we conclude today's webinar, No More Than the Investigators, Risk and Data Mining, we hope you've gained valuable insights into how data analytics is influencing today's healthcare enforcement landscape and what steps your organization can take to stay ahead of potential risk. We're actually showing you on the screen now some of the resources we've already mentioned, but we'll make sure those are sent out to you as well. On behalf of Kohler Healthcare Consulting, thank you for spending part of your day with us. We appreciate your participation and engagement. We'd like to extend a special thank you to Charlotte and Kalita for sharing their expertise and practical guidance. We also appreciate the thoughtful questions that were submitted throughout the questions. If we missed anything, we'll make sure to review it and we'll follow up with an email to you. Before you leave, you're going to see a brief post-webinar survey. That feedback helps us continue to improve our educational programming and also develop future topics that matter most to healthcare leaders. We go to the next slide, please. All right, and then one more slide, please. So within the next week, you're going to receive a follow-up email that includes a link to this webinar recording, then the presentation materials and the supplemental resources. So you saw that on the one slide, but we'll make sure all those links that we discussed, we will send those out to you as well. But we want to highlight this next one for you. This is information about our upcoming webinar, Cracking the Code, 2027 ICD-10 CM Changes, presented by Heather Dunlap on September 16th. So you guys want to go ahead and block your calendar for that because that's always one of our more popular webinars. Okay, one more slide, please. We encourage you guys to stay connected and continue the conversation as healthcare compliance, reimbursement, and enforcement continue to evolve. Thanks again for joining us. We hope to see you at a future Kohler Healthcare Consulting event. Have a wonderful day.